Good afternoon. I'm very excited to be here to share our first robotic transplant with you guys. And this is the first robotic heart transplant, not only in the TMC, but also in the United States. The first robotic adult heart transplantation in the world. The first robotic heart transplant without open sternum or chest incision through a subxiphoid incision in the world. So I'm going to share with you the journey, how we come up with the idea, how we get it done, so that you can see that a lot of things happen during just look like a complicated but also simple procedure that with innovation, with potential opportunities for a lot of innovations and new technology and how we can do things totally different, transforming the future cardiac surgeries down. That meaning no more sternotomy. Say no. If someone wants to operate on you, say, hey, I'm going to open your sternum to do your heart surgery, the first thing you think about is saying, okay, let me think about that. Can be a better way. You should not always open someone's chest to do it. Now we demonstrate to you that even heart transplant can be done without opening the chest. So the other valve surgery, bypass surgery, all the other surgeries can be done without open heart surgery. I'm going to try to. So heart transplant remains the gold standard for the treatment for end-stage congestive heart failure in the United States. And then there's about 250,000 end-stage congestive heart failure patients that needing desperately some kind of therapy, either mechanical circulatory support or heart transplant, or some aggressive treatment. And then sternotomy has been always the gold standard, the standard approach to do the heart transplant ever since Dr. Christine Bernard performed her first heart transplantation in 1967. That's the gold standard, has been always done like that way. Nobody has ever changed, period. And the United States, even harder because transplant is heavily regulated by the CMS, by UNOS. Nobody dares to change it, even think about doing something to change the gold standard or conventional way of doing heart transplant. But as you can see, the heart, with sternotomy, there are problems. Sternotomy meaning you have to split the sternum completely. With the bone marrow, and when you open the sternum, the bone marrow bleeds a lot. And in particular, in heart transplant patient, if you lose more blood, you end up needing blood transfusion. When you transfuse someone, you introduce the antibody to the recipient, and subsequently can affect the donor, the transplant organ longevity that increased because of increased risk of rejection. And also the bone healing takes forever, especially someone taking triple immunosuppressant. And then the sternal complication in heart transplant patient is reported about 10%, including non-healing, infection, and so on. It is very challenging, real problem for surgeons to deal with after heart transplant. So is there a better way to perform heart transplant without open the chest, without open the sternum? So yes, the technology can transform the way we perform surgery. In this case, is the robot. As you can see, the first robotic system was introduced to us in 1999, and then that's first generation. It was very difficult to use. Now we're at the fourth generation, now recently fifth generation. And then that actually, the fourth generation is much easier to use now, especially used in the cardiac surgery, and make it truly doable. In the old days, first three generations make it hard to operate inside the chest, inside the small cavity. Now with the fourth generation, now with fifth generation, the robot technology is there now for us to operate inside the heart. As you can see, my personal journey to embrace the robotic surgery. In 2019, we assembled a team at Baylor Medical Center to perform robotic surgery. As you can see, in 2019, and we only did 43 cases. Majority of surgery is still done with open approach. But if you look at it, 2024, a year ago, that flipped. And first time, robotic surgery surpassed the conventional sternotomy surgery. Now, this first 6 months of 2025, that gap is even bigger by the end of this year, and then that will do probably way more the robotic approach than the conventional approach in the history of Texas Medical Center, Texas Heart Institute. As you can see, this is the typical setup and daily routine at the Baylor St. Luke's Medical Center. So right now, we can do almost majority of the cardiac surgery that performed using robotic technology that include mitral valve surgery, tricuspid valve surgery, coronary artery bypass, and pacing lead, congenital heart defect, ASD, VSD, and then benign cardiac tumor. Now, recently, we added heart transplantation. Basically, all the cardiac procedures now can be done using the robotic technology. Now, let's look at back the transplant, heart transplant. If you look at heart transplant and what it entails in heart transplantation, basically, you cut out the old heart, and then you put a new heart in. That involves sewing the atrium together, sewing the pulmonary artery together, sewing the aorta together, and then sometimes vena cava, HVC, IVC. And then we basically, when we do all the other cardiac procedures in the valve, congenital heart, mitral valve, tricuspid valve, basically we day in, day out, we do all these procedures every day, but pieces. Now we put all the daily routine procedures together to do the heart. Basically, combine all the procedure steps we do together and then put in one piece. That's called robotic heart transplant. And then we also thought of a way how can the heart is big, sick heart is big. How do we take it out? And that's a challenging part. Based on our prior history, that's experience count. In the old days, when we performed the insertion of the first generation of artificial heart, total artificial ventricular assist device. We have a huge device implanted in the belly. Portion is the pump is the belly, graft is sold to the aorta, inflow cannula is sold the apex of LV. It was done through the trans-abdominal approach together with transthoracic, transsternal. So we change out the old pump with the new pump, since the old pump typically failed after 18 months. We go back in, we change it out. We find out there's a space in the pre-peritoneal space, subxiphoid space, that can get to the heart and without open the chest, without enter the belly. It's called pre-peritoneum subxiphoid process. So we use this process for taking out the heart out and then inserting the new heart in. As you can see, this is the patient. And the young man has had a history of heart failure for 2 years and had a stroke due to thrombus formation in the LV because heart is weak. So he ended up coming to the hospital in January this year and ended up requiring ECMO due to cardiogenic shock. Subsequently, he required left ventricular assist device, right ventricular assist device. He was stuck in the ICU bed for 3 months, waiting for a heart to arrive. So we finally, in March this year, they're the perfect donor for this gentleman, local donor, a big size donor, and fits in his heart perfectly, and everything looked good. We decided to take this heart for the robotic transplant. As you can see, that's what's planning. This patient has 2 devices, as you can see on the let me see where it gets pointed. Anyway. The cannula is a right ventricular assist device and a subclavian left ventricular assist device. So we made the incision about 5-inch incision through the upper abdominal midline, cut out his cartilage and of the xiphoid process. And then using soroscope, enter through the rib space, insert the robotic instruments to do the cutting and the sewing and pull the heart out from the pre-peritoneal space and inserted the heart out through inside, through the subxiphoid process. As you can see that on the left side of the picture, my assistant is working, looking through the abdomen, looking up into the chest. I'm sitting on the computer console to control the device, the cutting and the sewing of this machine. And then the total, even with our first totally fully robotic transplant, the total ischemic time is 3 hours, 55 minutes. is within the standard acceptable time of heart transplant, which is 4 hours. So the patient did great, minimal blood loss, and the recovery was very uneventful. We kept him in the hospital a little bit longer because of his first robotic transplant. And then otherwise, there was no issues. And you can see him on day 0 when he was called about the heart availability, and until 3 months out and 5 months out, he was hiking. So this is a great transformation and for this patient using the robotic transplant technique that he had a speedy recovery. And we are very excited that this can be applied to the future many other patients, and also open the door widely for all the future robotic surgery that can be done, and also all the potentials of new innovations that we can have together with you guys, and to make next transplant or the future robotic surgery even smoother, quicker, safer, and there are certain tools now we can use to develop for particularly performing the robotic heart surgery. I'll stop here. We will have a discussion later. Thank you for your attention.